Hello. No, I'm not. Good seeing you.
Hi. Introduce you really quickly to Celia.
Hi Celia, how are you? You're the farm expert. Welcome.
That's great. Celia just joined yesterday. Was her first day at HBC.
It's funny, when I look back at my
That's okay.
to get the regs, I went back to the last meeting and I was pulling it out.
This morning.
Question up on the top was, do we have the right staff?
Yeah.
So, yeah. Celia.
They tackle
Oh, yes, I did. Yes, I did get that. I did. Thank you for doing that. I was like, oh, sorry.
Yeah. Good afternoon. This hearing is being held by the Health Policy Commission to receive public comment on the proposed regulations 958 CMR 12.00 drug pricing review pursuant to Mass General Law, Chapter 30A. The purpose of today's hearing is to receive comments from the public rather than to engage in a discussion or answer questions. Any persons wishing to record today's hearing must speak with the Commission's Deputy Chief of Staff, Hannah Klumak, prior to doing so. This hearing is being recorded by the Commission, and the video recording will be posted online. A sign-up sheet is available by the door for persons wishing to present oral testimony. The Commission will determine an order for testimony. Please listen for your name or your organization panel to be called. You may provide oral testimony only once. Please focus your testimony on the proposed regulations and limit your remarks to 5 minutes. Remarks made by groups of no more than 4 will be limited to 10 minutes. Persons presenting oral testimony today are encouraged to submit a written copy of their testimony as well. Anyone who wants to submit written testimony should send submissions to hpc-regulations@state.ma.us or to Lois Johnson, General Counsel, at the mailing address included in the hearing notice. All written testimony must be submitted by 5 p.m. Friday, December 20th. All testimony is given equal weight, whether written or oral. Please note that all written comments submitted to the Commission may be posted on the Commission's website and released in response to requests for public records. I will now turn the meeting over to our Executive Director, David Seltz.
Good afternoon, everyone. I'm David Seltz, Executive Director of the Health Policy Commission. Welcome to this public hearing on the pharmaceutical review proposed regulation. First, welcome to the public here. Welcome back to those of you who were here earlier today, and welcome to the members of the public who are watching this online. Before we dive into the public hearing, I want to quickly just introduce the Health Policy Commission team who's here at the table today, and then turn it over to Lois Johnson, our General Counsel, to provide a brief overview of the proposed regulation. So very briefly, around the table to my far right, I want to introduce Celia Siegel, who is our new Associate Director of Pharmaceutical Pricing and Policy. This is her second day at the Health Policy Commission. So thank you, Celia, for joining us, and she will be overseeing the HPC's role in this process. She's part of our market oversight team, which is led by Kate Scarborough-Mills, our Senior Director for Market Oversight and Transparency. To my immediate right is Lois Johnson, our General Counsel. And pleased to be joined also today by Commissioner Kreider and Commissioner Blakeney. So thank you both for being here today. So before we dive into the public hearing, as I said, I do want to provide a brief overview of this process and the proposed regulation. And so we'll now turn it over to Lois Johnson.
Thank you, David. Great. The proposed regulation that is the subject of today's hearing implements the HPC's new authority to conduct drug pricing reviews for certain manufacturers and drugs referred to the HPC by the Executive Office of Health and Human Services, which operates the Mass Health Program. The HPC's authority is codified in General Law, Chapter 6D, Section 8A. As presented in more detail to the HPC board on November 20, I'm briefly going to provide an overview of that statutory authority, both for the Executive Office and HPC. So under the law, EOHHS, operating the Mass Health Program, and I'm going to use Mass Health as a shorthand today, can negotiate directly with drug manufacturers for supplemental rebates, in addition to those that are mandated by federal law. If those negotiations are unsuccessful, then for certain high-cost drugs, Mass Health may identify a proposed value of the drug and gather data and information and potentially hold a public hearing. High-cost drugs are defined under the statute as those with an annual post-rebate per utilizer cost to Mass Health of $25,000 or more, or an annual post-rebate aggregate cost to Mass Health of $10 million or more. Based on the information and comments received through that process, Mass Health then updates its proposed value of the drug as necessary and solicits further negotiations with the manufacturer. If those subsequent negotiations still do not result in a supplemental rebate agreement, then Mass Health may refer the manufacturer to the HPC for review. So for the HPC process, which is triggered only by a referral from Mass Health, upon referral, HPC is authorized to collect information related to the manufacturer's pricing of the drug. Based on those submissions from the manufacturer and other information, HPC may identify a proposed value of the drug, a proposed supplemental rebate, and in a two-step process may ultimately determine whether the pricing of the drug is unreasonable or excessive in relation to the HPC's proposed value. And that two-step process, which is on the right hand of the slide, involves a determination that the pricing is potentially unreasonable or excessive, That triggers an additional review of information from the manufacturer and other stakeholders, and then a final determination on whether the pricing is unreasonable or excessive in relation to the HPC's proposed value of the drug. The proposed regulation, which was released by the board on the 20th of November, builds out the process laid out in statute and specifies the procedures for collection and review of information regarding that referred manufacturer's pricing practices and the process for determining whether the pricing is unreasonable or excessive in relation to the drug's value. The law also requires the HPC to develop a standard reporting form to collect information from manufacturers in this process. A draft form was also released for comment on November 20th, and we seek information, we seek comment from manufacturers in particular and other stakeholders on that draft form, as well as the proposed regulation, both in today's hearing and also through written comments, which, as the Commissioner stated, are due next Friday.
Okay. Thank you, Lois. We are now ready to hear public testimony. When called to testify, please state your name and identify the organization you are representing. Please try to speak directly into the microphone slowly and clearly for the closed captioning. We will take elected and state officials first. Are there any elected or state officials here who would like to testify? Not seeing any. We will go to our first panel. Alyssa Vangeli, Healthcare for All, Michael Rubenstein, Greater Boston Interfaith Organization, and Samuel Botsford, the Jewish Alliance of Law and Social Action. Welcome. Again, please state your name and your organization for the record.
Good afternoon, Director Seltz, Vice Chair Cohen, General Counsel Johnson, and other members of the HPC board and staff. Thank you for the opportunity to testify this afternoon on proposed regulation 958 CMR 12 drug pricing review. My name is Alyssa Vangeli. I'm co-director of policy and government relations at Healthcare for All. Healthcare for All advocates for health justice in Massachusetts to promote health equity and ensure coverage and access for all. I'm here today to provide testimony both on behalf of Healthcare for All and the Massachusetts Prescription Drug Affordability Coalition, which includes groups that represent consumers, seniors, children, individuals with disabilities, providers, unions, mental health organizations, health policy experts, and faith-based groups, including Greater Boston Interfaith Organization and Jewish Alliance on Law and Social Action, who will be testifying following my comments. Overall, we strongly support the proposed regulation and would like to highlight a number of provisions that we believe are particularly important in making prescription drugs more affordable. First, we strongly support the process for HPC to require information from a manufacturer via the standard reporting form following referral from EOHHS, including specifying the comprehensive information to be included in the form and the parameters for timely submission of information to the HPC. Second, we strongly support the provisions specifying that following a determination that a manufacturer's pricing of a drug is potentially unreasonable or excessive in relation to the value of the drugs, that HPC shall request information from other interested stakeholders, including patients, providers, provider organizations, and payers, and that HPC may hold a public hearing. And third, we strongly support the provision that specifies that following a determination by the HPC that a manufacturer's pricing of a drug is unreasonable or excessive in relation to the proposed value, that HPC must post a notice on its website with the name of the manufacturer and the drug reviewed, the proposed value of the drug, and the HPC's determination. These provisions are critical to providing a robust public engagement process and ensuring both accountability and transparency for unreasonably or excessively priced drugs. We will be submitting written testimony on behalf of the coalition, further detailing our support, and I thank you again for the opportunity to testify.
Thank you.
Hello, I'm Sam. I'm Sam Botsford here on behalf of JALSA. I want to thank you all for the opportunity to speak to you today. JALSA provides a voice in the political process for our Jewish community's long-standing moral commitment to equity and justice. It is these foundational faith values that have brought us here in partnership with Healthcare for All, Greater Boston Interfaith Organization, and other members of the Massachusetts Prescription Drug Affordability Coalition to support and strengthen the critical regulations we are discussing today, as was outlined in Alyssa Vangeli's opening testimony. In particular, I would like to speak to the importance of ensuring that the public is included and kept informed regarding the processes that would be established through these regulations. In addition to my work with the Jewish Alliance for Law and Social Action, I also serve on the board of directors at the Massachusetts chapter of the National Alliance for Mental Illness and as a peer specialist supporting others with mental health conditions. In these roles, I have witnessed firsthand the power of innovative and accessible pharmaceutical treatment. Patients' lives are restored, and they are able to move forward to build lives of stability and meaning. We are thankful to live in a hub for this innovation and treatment here in Massachusetts. But despite unprecedented advancements in medicine, many people remain unable to benefit because the high cost of prescription drugs renders them inaccessible. This places vulnerable patients' health and well-being in peril and creates significant inequities in who ultimately is able to access care and experience recovery. The Mass Health Program is critical in alleviating these inequities, and as such, we must remain committed to its sustainability and promote its continued access to life-changing and life-saving treatments. In reducing costs to mass health, these regulations help provide for this future. When we discuss the high cost of prescription drugs, it is this human impact that is most at stake, and these patients as beneficiaries who stand to benefit or lose the most. As such, our communities deserve a place and a voice at the table, as well as transparency regarding processes that have the potential to profoundly impact our lives and systems. In Massachusetts, we have the potential to serve as policy innovators in reducing the cost of prescription drugs, acting on our shared commitment to help residents throughout our Commonwealth. However, to be successful in this initiative, we must ensure that the insights and experiences of patients and the broader public are included in determining what is needed. Thank you for your work on this issue, and we look forward to continuing to partner with you to secure health equity and justice for all residents of our state. Thank you.
Thank you, Sam.
Good afternoon, Commissioner Cohen, Director Seltz, Commissioner Blakeney, Commissioner Kreider, and members of the Health Policy Commission staff. My name is Michael Rubenstein. I am co-chair of the Greater Boston Interfaith Organization Healthcare Action Team. The Greater Boston Interfaith Organization, or GBIO, is comprised of 41 dues-paying institutions representing over 45,000 people in Greater Boston. GBIO is here with Healthcare for All, the Jewish Alliance for Law and Social Action, and other members of the Massachusetts Prescription Drug Affordability Coalition to voice our support of the regulations you have drafted. We believe the strong regulations will help people by lowering prescription drug costs for mass health, thereby freeing resources to better serve the people of Massachusetts. GBIO is also here today to stand up for a set of values that are expressed in our laws and regulations. It is our hope that you continue to keep these values in mind and ensure that they are faithfully embodied as you finalize proposed regulations 958 CMR 12. We value transparency in how the prices of goods and services purchased by the government on our behalf are established. In particular, when government research is used as the foundation for new medicines, we want the impact of our tax dollars used to pay for that research to be appropriately recognized. We value the opportunity to participate as citizens through public hearings and other testimony to ensure that our perspectives are incorporated in your publication of reasonable prices for unreasonably priced drugs. We value clarity in the regulations so that the values they embody are recognized and acted upon by future regulators. And while we value the ability for individuals and businesses to make reasonable profits on the products and services they sell, that ability loses its value when it is distorted by a market structured with unfair rules. When a seller inflates the cost of life-saving products due to their own control of the supply and a buyer's inability to negotiate, it is time for our government to act on the buyer's behalf. We have shared many stories of why the government needs to act. Chris and many others, people with diabetes, are unable to rely on access to life-saving insulin. Faith had to ration her husband's kidney medication because she couldn't come up with the $353 for a 10-day supply as his pills ran out before the end of the month. Most importantly, so many of us are unable to get the care we need through Mass Health as millions of dollars are diverted to pay unreasonable prices for expensive prescription drugs. GBIO and other members of the Massachusetts Prescription Drug Affordability Coalition are grateful for your action today. It is our hope that, as you finalize these regulations, you keep the values of transparency, citizen participation, clarity, and fairness all reflected in these regulations as they are faithfully executed now and in the future. Thank you very much.
Thank you, Michael. Commissioners have any questions for the panel? Great. Thank you. I have no other speakers who have signed up. Is there anyone in the audience who wishes to testify this afternoon? Again, if you can give us your name and organization.
I'm sorry, I attempted to register by email yesterday, but it hadn't gone through. Thank you so much for the opportunity to testify. Thank you, commissioners and staff of the Health Policy Commission. My name is Colin Killick. I'm the Executive Director of Disability Policy Consortium. We're a statewide disability civil rights advocacy and research organization. I'm presenting my testimony on our own behalf today, but by the 20th we will be presenting joint written testimony that will be on behalf of not just ourselves, but also NAMI, Disability Law Center, Easter Seals, Boston Center for Independent Living, and Mental Health Legal Advisors Committee, among other major disability rights organizations across Massachusetts. On behalf of the Massachusetts disability rights community, we are here to express support for the aims of this regulation, but concern over some of its methods. Our members are reliant on pharmaceuticals to survive, to thrive, to be independent. When prices are high, we bear the brunt, and we support measures to address high drug prices across a variety of domains, from including our strong support for H1133/706, which would set an upper payment limit, as well as proposals to import drugs from Canada, federal efforts to license more generic drugs, and expanded transparency and disclosure provisions, such as the ones that appear in this regulation. We wholeheartedly support the provisions of these regulations that empower the HPC to demand information, hold hearings, and force drug companies to justify their pricing to the public. And I would echo the comments of Ms. Vangeli and the Massachusetts Prescription Drug Affordability Coalition, of which we are a member. However, we have strong concerns about several of the pieces that define how the Commission would determine what the value of a drug is. Particularly in Section 12.05, the regulation calls for evaluating a drug's price versus its therapeutic benefits, but provides no details on how those therapeutic benefits will be calculated, or any requirement that this analysis be disclosed to the public unless it is conducted by a third party. Likewise, there is no clarity provided over how the seriousness of a condition will be established, a troubling factor when many analyses of disabilities used in this sector rely on flawed, discriminatory survey instruments like the EQ-5D that, for example, presume that everyone who cannot walk is confined to bed. Subsection 2F refers to whether a drug has pharmaceutical equivalence, but provides no standard for establishing equivalence. In states like New York, as well as under private insurance, people with disabilities have been subjected to fail-first provisions that force us to take the cheapest drug first and work our way up to the one our doctors actually prescribe. A policy that proved fatal this year for beloved disability activist Carrie Ann Lucas, who died after a $2,000 inhaled antibiotic was deemed not cost-effective by her insurer compared to an equivalent drug. Without clarity on these definitions and processes, the disability community is highly concerned that this regulatory approach could lead to discriminatory and dangerous outcomes. We would ask that HPC consult with the disability community to develop protective standards that ensure the well-being of our community is safeguarded. We welcome the transparency provisions for third-party analyses under Section 12.08, but believe they did not go far enough. In essence, we believe that the required disclosures should take place regardless of whether a cost-effectiveness analysis is conducted by a third party or by the HPC or EOHHS, including full transparency of the methodologies and models used to determine cost-effectiveness. We would also ask that organizations representing people with disabilities be added to the list of stakeholders that must be consulted under 12.08D. More broadly, we think it's vital the board work with people with disabilities and the people with disabilities be represented on the commission and its advisory board, as our community will often be impacted first and most intensely by the decisions made by the commission. We are ready and willing to work with the commission to ensure we can achieve reduced prices without harming those who depend on sometimes expensive services for their independence and survival. Lastly, and I think most fervently, we feel that it is vital that these regulations contain civil rights protections for people with disabilities in the domain of what metrics are used. Certain measures, most prominently the quality-adjusted life year, are based at their core on the presumption that the lives of people with disabilities are worth calculably less than the lives of people without disabilities. They set values for the life of all people with a particular diagnosis or in a few broad categorical buckets. So all people with severe epilepsy, for instance, I believe it is defined as 2 or more seizures a month, something in that, that may not be the exact number, but in that domain, will have a value of say 0.6. So meaning the life of a person with severe epilepsy would have 60% of the value of the life of someone with no disability at all. And a treatment that would extend the life of a person with severe epilepsy by a year would be worth 60% as much as a treatment that would extend the life of someone with no disability. This means that 2 treatments that extend the lives of 2 individuals by the same amount, one will be judged less cost-effective than the other if the person whose life it extends is judged to be more severely disabled, a clear example of discrimination. The means by which these analyses are often concluded are also often based on deeply flawed pseudoscientific analyses in order to fit them into this framework. As an example, a recent analysis by ICER of drugs for treatment-resistant depression. The scale used by experts in depression is the PHQ-9, which is a 28-point scale for level of functioning, right? Extremely granular, highly receptive. These figures from 0 to 28 were crushed down to 3 categories: no depression, mild to moderate depression, and severe depression, which means that a treatment that reduces someone from being a 28 on this scale to, say, a 17 on this scale, a substantial increase in functioning, might get credit for no real improvement at all. We fundamentally believe that in the absence of explicit protections, should the HPC choose to use measures like QALYs, it would be in violation of both the Americans with Disabilities Act and the Massachusetts Constitution, specifically Article CXIV, which bans discrimination against people with disabilities under any program or activity within the Commonwealth. These are not niche concerns. Our nation's highest disability agency has called last month in a report for a complete ban on the use this is the National Council on Disability. It's called for a complete ban on the use of QALYs throughout all of Medicare and Medicaid. I will submit their report along with my written testimony. I would urge the commissioners to read it. QALYs have previously been banned for use in Medicare under the Affordable Care Act, and in the 1990s, an effort in the state of Oregon to use QALYs to determine whether treatments were cost-effective was struck down as violating the ADA. We think that would be a real possibility here. We think it would be appropriate here if these measures are used, and we don't want them to be. We want prices to come down. we need prices to come down for the sake of our community. We simply believe that we need not and must not choose between lowering prices and protecting the civil rights of people with disabilities and the fundamental notion that our lives are just as valuable as anyone else's. Thank you.
Colin, thank you. Any questions? No? Anyone else wishing to testify this afternoon?
I just want to thank you for your comments. I think people with disabilities often don't get a fair shake, and I think you've pointed that out very dramatically and very emphatically, and I thank you for it.
You're quite welcome. Thank you for this opportunity.
Thank you for having me. Susan Fendel, Mental Health Legal Advisors Committee. I just want to echo everything that Colin just said. However, I just wanted to add a few points. We believe that there should be a public hearing under the regulations, not may be a public hearing. And looking at identifying the proposed value of a particular medication, this is of critical concern to insureds and patients because it is quite likely that private insurance companies and Medicaid will, or Mass Health, excuse me, will look at the value that is determined and either tier it to a higher tier level, which means that patients are going to pay more for a medication, or refuse to cover certain high-value drugs. And so in determining the value of a drug, there are conflicting interests. We want prices to come down. On the other hand, we don't want people who need particular name brand high-price medications to either pay more or not have coverage for those medications, if that's what would be appropriate. In looking at some of the criteria to determine proposed value, we would ask that not just clinical efficacy be looked at, but also clinical effectiveness. Clinical efficacy is how the drug performs in a controlled situation. Effectiveness is in real life. And in real life, some medications have such serious side effects, or side effects that patients consider serious, perhaps weight gain, that patients cease to take the medication, and the medication is actually not very effective because people don't use it for much time. And then in terms of pharmaceutical equivalence, there needs to be consideration of whether the fillers in the medication cause side effects for some portion of the population. Because even though the active ingredient may be equivalent, the inclusion of these fillers has a different effect on different people. And that's it. Thank you very much.
Susan, thank you.
Thank you, Susan.
Any questions? Thank you. Anyone else wishing to testify? Comment? Sure.
Thank you all for testifying, and this is the beginning of a really difficult process, I think, for us in the HPC. I jotted down a couple of the words, potentially unreasonable, proposed value, moral commitment, equity. These are really, we're getting into a real gray, a very difficult zone. I worry about drug development for disabilities. A piece in the paper this morning about the almost certain likelihood of a gene splicing success for Duchenne muscular dystrophy. Now, that's not going to affect 800,000 diabetics in Massachusetts, 250,000 of whom are in Medicaid. But it's going to probably affect and utterly create life-saving opportunity for 50 mostly young boys with Duchenne's muscular dystrophy. So the trade-offs here are enormous if we don't get it right and create an environment where drug development does not occur because the cost of drug development can't be recovered. So I just want to make the comment, and for anyone who's interested, and I think everybody's interested because they're in this room, there was a wonderful piece in the Wall Street Journal this morning by Scott Gottlieb, who just stepped down as commissioner of the FDA on this subject, and so it's very timely. And if you want to learn more and help us in what are really difficult qualitative judgments, please read those and come and testify again. Thanks.
Thanks, Chris. Not seeing anyone else who wishes to testify, I'm going to declare the hearing closed. I want to also remind folks that written testimony will be accepted until 5 p.m. next Friday, December 20th, and that should be directed here to Lois Johnson, our General Counsel. Any other points? No. If not, thank you all for your attendance today.